This video is on inflammatory bowel disease. Inflammatory bowel disease. Now, inflammatory bowel disease is a disease that causes inflammation in your bowels. So it's an inflammation of bowels. And it's not actually one disease, it's actually a group of diseases. But for your intents and purposes for the step, and basically for life, when anyone talks about inflammatory bowel disease, they're talking about two things. They're talking about ulcerative colitis, and they're talking about Crohn's. These are the two most common ones. Now there are a few others. There's microscopic colitis, there's Behçet's disease. But for your intents and purposes, whenever someone mentions IBD, inflammatory bowel disease, they're talking about ulcerative colitis and they're talking about Crohn's. And that's what we're going to talk about in this video. Okay, so these cause inflammation of the bowels. How do they cause that? No, nobody really knows. There seems to be a multifactorial theory going around that the inflammation is caused by autoimmune factors and environmental factors and bacterial factors. Some theories that are going around says maybe there's inflammation of your bowels due to some autoimmune attack or maybe some environmental stressor, and that inflammation can weaken your bowel walls and bacteria can come in and cause inflammation and you get inflammation of your bowels. Whatever the case may be, we're not quite sure. But we do know that it's very common, and we do know that ulcerative colitis and Crohn's are the main players. Now, inflammatory bowel disease doesn't only affect your bowels. However, it primarily affects your bowels. That's why we're calling it inflammatory bowel disease. But you should just know, for your general knowledge, that it affects many other things. But because it primarily affects the bowels, we're going to talk about it in this GIT block. Kind of like in sarcoidosis, it affects a whole host of things, but because it primarily affects your lungs, we talked about it in our respiratory block. Rheumatoid arthritis affects a whole bunch of things, but because it primarily affects your joints, we talked about it in our MSK block. So just know inflammatory bowel disease affects a whole host of things, but because it primarily affects your bowels, we're going to talk about it here in our GIT block. Now, when you learned about ulcerative colitis and you learned about Crohn's, you probably learned it in the same way I did. You get a whole list of the different findings in ulcerative colitis and a whole list of the different findings in Crohn's, and you kind of compare and contrast. That's how I learned it in school. That's how Pathoma teaches it, and shout out to Dr. Sitar. So that's how a lot of books teach it, a lot of online resources. So they all do it like that. I just want you to know that all those factors can be broken up into two categories. They can be broken up into location of the inflammation and the nature of the inflammation. Nature, whether it's transmural, aka inflamed through the entire length of the bowel wall, transmural, or not transmural. Are you telling me that all those factors that they list can be broken up into these two things? That's exactly what I'm telling you. All right, so if you don't believe me, well, you can just watch. Shout out to Bruno Mars. So we'll start with location. Ulcerative colitis starts near your rectum, and it goes continuously up your colon. That's why I call it colitis. So ulcerative colitis starts at your rectum and moves continuously up the colon. So let me just draw it out. This is your rectum, and this is your colon, and it'll start here, and it'll move continuously up. All right, Crohn's doesn't do this. Crohn's likes to skip around. All right, it can skip anywhere around that tube that is your gastrointestinal tract. It can even affect your mouth, but it likes the terminal ileum the most. Terminal ileum, very important fact, you know that? And it often spares the rectum, so that's the difference right away. Spares rectum. Not only does Crohn's like to skip around grossly, macroscopically, it also likes to skip around microscopically. So you can have lesions in one area and then areas that have no lesions. Lesions in one area, then areas with no lesions. We call this cobblestoning because it kind of looks like a cobblestone. So it can cause cobblestoning of the bowel. All right, so let's just skip around. If we drew it out, if we drew out the bowel, let's see, there's your rectum, there's your large intestine, and then goes to your small intestine, etc. It can affect here, it can affect here, it can affect here, it can affect there. So let's just skip around. All right, that's very important. You should know. Why is it important? Because it shows up clinically. So in ulcerative colitis, you're gonna have more bloody diarrhea. Why do you have more bloody diarrhea? Because it's right down near your rectum, right down by your colon. And so you have inflammation there, the blood can just leak out into your poo or your butt. So it has more commonly bloody diarrhea. Bloody diarrhea. You also have pain in your left lower quadrant. Why is that? Because that's where your colon is. So left lower quadrant pain. And the most important fact that it starts at your rectum and continuously goes up your colon is that you can cure it by cutting this part out. You can cure it with resection. Cure with resection. Cut out the bad part, you don't have ulcerative colitis anymore, do you? No. Can you do that with Crohn's? It's very difficult because it likes to skip around. What are you going to cut out here, cut out here, cut out here, and try and mix them all back together? It's very difficult with Crohn's. So instead, Crohn's is a little bit more limited. All right, that is the location part. How about the nature of inflammation? The nature of inflammation is whether it's transmural or not. Ulcerative colitis is usually not transmural. It usually starts superficially. So it'll start at your mucosa and cause inflammation there, and then if it's really bad, it'll move on down, tunnel down to your submucosa, and if it's really bad, then it'll move on down to your muscular propria. But very rarely does it get all the way through your entire bowel wall. So I'll just write, usually not transmural. Usually not transmural. Crohn's is. Crohn's is transmural. Affects the whole bowel wall. So right, transmural. Why is it transmural? No one knows. No one knows what causes IBD in the first place. There are some theories. We can talk about one of the location theory. We'll call it the location theory because Crohn's affects your rectum. If you have inflammation there, then things like bacteria can go in and go into your bowel wall, and neutrophils will come in and cause acute inflammation. In Crohn's, however, it can affect things like your terminal ileum, things like your small intestine, and you'll have inflammation there, and you'll have bacteria that can go in and cause inflammation. But you also have things like food antigens. You also have things like digestive enzymes that are more common in the upper area of your GIT as opposed to the lower area. And so you can have not only neutrophils coming in causing acute inflammation, you can also have macrophages coming in, which is the mediators of your chronic inflammation. So you get this chronic inflammation in Crohn's, this increased duration of inflammation in Crohn's, and that can cause it, that inflammation is spread throughout your entire colon, transmural. Another theory is that in Crohn's, in the bowels of Crohn patients, they see a lot of fat. You have so much fat that wraps around your bowels. We call that fat wrapping. Fat wrapping. Why is that important? Fat is not just this inanimate sheet under your skin. Fat adipose is made out of adipocytes. These are living cells. These are living things. They do things. They produce things. They produce hormones, don't they? They produce leptin. We just talked about that. They also produce things like cytokines. So you have enough fat wrapped around your bowels, you have enough cytokines, and that can increase the duration of inflammation, cause that inflammation to spread throughout your entire bowel wall. So fat wrapping can also play a role in making Crohn's transmural. These are all just theories. They're not going to test you on it. That's why I didn't even bother writing them down. But just kind of know, or just at least have the curiosity of trying to look up what's the latest developing theories. Okay, so Crohn's is transmural. Why does that matter? Because it shows up clinically. It shows up clinically. We said that ulcerative colitis it starts superficially, and because it starts superficially, you can kind of see ulcers. That's why I call it ulcerative colitis if you haven't figured it out by now. Because it's ulcers in your mucosa, because it starts superficially. So you see ulcers, and because you have those ulcers, you can have scar tissue, these little nodules of scar tissue that look like polyps. But they're not polyps, they're scar tissue, so we call them pseudopolyps. Pseudopolyps. You can have it spread deeper and deeper from your mucosa to your submucosa to your muscular propria, and that loss of muscles can cause it to stop functioning, and it'll start to fill up with poo and start to dilate. We call that megacolon, toxic megacolon. So a patient that has a history of ulcerative colitis, now all of a sudden they can't poo. You image them and their colon's just dilated, just filled with poo. Toxic megacolon. And if it keeps going down through the layers, it can eventually perforate. It can eventually become transmural. Not only can it become transmural, it can affect the muscles that are outside of your bowel wall. There are muscles that are outside your bowel wall that constrict your bowels and make it saccular. If you ever looked at the large intestine, it looks kind of like these little sacs, right? If you affect those muscles and you knock them out, then you lose that formation of the saccular appearance and they just become straight. We call that straight pipe or lead pipe appearance. So you destroy that muscle, then your bowels look like a lead pipe. Comprende? Ulcerative colitis, that's ulcerative colitis, that's superficial inflammation. Crohn's, we said was transmural inflammation. Affects the entire length of your bowel wall. So we said it might be due to chronic inflammation from macrophages. What do you see in chronic inflammation with macrophages? Don't you see granulomas? That's exactly what you see in Crohn's. So granulomas. You're going to see scar tissue like you see in ulcerative colitis, but you're going to see more scar tissue because you have more inflammation. So you see so much scar tissue that it constricts your bowel. If you do a barium swallow, see that barium flow through, then the area of your bowel that's affected will be so constricted with scar tissue that it'll look like a string. Sometimes we call it string sign. All right, so I'll say image equals string sign. String sign. One of the most important things that you should know is that because it's transmural, it can perforate through the wall much more quicker than ulcerative colitis. It can perforate the wall and cause a fistula, a connection of your bowels to some nearby structures. It can connect your bowel to your bladder, and you'll have poo coming out of your urethra. It can connect your bowel to your vagina. You'll have poo coming out of your vagina. So if you see those signs, then it's Crohn's, okay? So I'll just write fistula. What do I want to write? Poo coming out of places? No, that's not scientific. But fistula, dead giveaway. I've seen so many questions to talk about a patient that has poo coming out where it shouldn't be, or a fistula, or some sort of abscess or infection because the poo's just leaking everywhere. They're talking about Crohn's. So you can also have perianal disease, which can include a rash around your perianal region. Why is that? We said Crohn's spares your rectum, so why is it affecting your perianal region? Well, if you have leakage of poo around the area, then it can cause inflammation there. Now, a question I got was, why don't you see lead piping on Crohn's? Doesn't it cause transmural inflammation? Wouldn't it affect the muscles on the outside that caused the formation of these saccules? If it affects those muscles, shouldn't it cause lead piping? It does. However, because ulcerative colitis is one continuous area of inflammation, you can really appreciate it. It really looks like a lead pipe. Whereas Crohn's skips around, you might have one flat area here, one flat area there, and you can't really appreciate it there. All right. So whenever you see lead pipe, it's more associated with ulcerative colitis. Got it? Good. All right, let's move on. We said IBD mainly affects your bowels, but it can affect other things. Let's talk about those other things. We'll just call them extra GIT manifestations. They're commonly due to inappropriate immune response. Remember, that's one of our leading theories of why we have IBD in the first place. So inappropriate immune responses, it can affect your skin, cause things like pyoderma gangrenosa. That sounds terrible, and it is. Look up the pictures. You get these gangrenous tissue, these skin sores all over your body. You can have erythema nodosum. These red nodules is due to inflammation of the underlying fat. Usually around your shins. We see this in sarcoidosis. We can also see it in IBD. It can affect your eyes. Uveitis. We said uveitis is linked to autoimmune conditions because your uvea is the middle layer, so it's very difficult for things like bacteria to get to that. So anytime you see uveitis, think autoimmune conditions. Mouth ulcers. We just talked about the oral cavity. Didn't we talk about these mouth ulcers, these aphthous ulcers, and we said it can be spontaneous, but it can also be linked to autoimmune conditions. Well, here it is again. And then arthritis. Never ever forget your HLA-B27 arthritis. We said psoriasis was one. I always forget that. I always forget. Talk about a patient that has the psoriasis, this scaly plaques, and then have joint pain, and I never put it together. So arthritis, psoriasis was one. IBD is one. Ankylosing spondylitis. Okay, reactive arthritis. So all the HLA-B27s, never forget it. And IBD is one of them. So those are your extra GIT manifestations. Now there are some complications to ulcerative colitis and Crohn's that you should know. Things that are seen more frequently in these diseases. And there's one that's specific to ulcerative colitis, so you gotta know it cold. Ulcerative colitis patients seem to be at an increased risk of primary sclerosing cholangitis. Colon, anything that, colon? It makes it sound like I'm saying colon, but I'm not. I'm saying colon means bile duct. So inflammation of your bile duct, cholangitis. Sclerosing meaning a narrowing. So there's some sort of narrowing inflammation of your bile duct. Here we think that these patients that have this autoimmune condition that's affecting their bowels, causing ulcerative colitis, can also have autoimmune inflammation affecting their bile ducts, especially the bile ducts that are near the liver. And it can cause this inflammation, causes scar tissue and cause constriction of these bile ducts. And that's not good. Your liver can't drain and your liver will start to die and you'll have liver failure. So autoimmune fibrosis of ducts near liver. Ducts near liver equal liver failure. So it's not too hard to identify. They'll give you a history of a patient with ulcerative colitis. So they might say, patient that has bloody diarrhea, left lower quadrant pain, imaging shows lead pipe, all of a sudden develops jaundice, hepatomegaly, pruritus from all that backed up gunk. What do they have? Easy peasy. Primary sclerosing cholangitis. Then they might ask you, what labs would you order to confirm? P-ANCA. It's highly associated with P-ANCA. What is P-ANCA? Tell me everything you know about P-ANCA. P-ANCA, they said it was an antibody against your neutrophil, especially myeloperoxidase. I'm not gonna write that down, but you should know that. Okay, so they might take it one step further and ask you what labs you want to order. You want to order P-ANCA. So that's ulcerative colitis. What about Crohn's? Crohn's affects most commonly your terminal ileum. That's where your bile salts are absorbed. If you can't absorb bile salts, then you will have increased risk of gallstones. Gallstones. Makes sense. So how will it appear on the question? Well, it'll give you all the history of someone that has Crohn's. So history of Crohn's. They might have, I just love the fistula. They always talk about the fistula. So patient with diarrhea, abdo pain, they're having poo coming out of their vagina. And then they might ask, then they might say, they were treated and then a month later they developed right upper quadrant pain that got worse every time they ate fatty foods. They got gallstones. All right, something else you see in Crohn's? Kidney stones. Especially calcium oxalate. Why do you see calcium oxalate stones? Well, you'll have increased oxalate when you have Crohn's. Why is that? Crohn's is a malabsorptive condition, correct? In your gut, whenever you have too much oxalate, calcium will come and bind it to kind of reduce the oxalate levels. However, if you have malabsorption, if you have free-flowing fat that you're no longer able to absorb, then fat will bind to calcium and knock it out, and you'll just have oxalate, free flowing. You know, that increased oxalate can give you calcium oxalate stones. Easy peasy. All right, so we just talked to death about IBD. Let's talk about the treatment. We'll write back out our proposed mechanism of IBD. It's proposed, but it's the best we got. So we said there's autoimmune conditions, there's environmental factors, there is bacterial factors. Let's talk about ulcerative colitis. We're going to try and work on these factors. The mainstay treatment of ulcerative colitis is a drug called sulfasalazine. Sulfasalazine is a combo of sulfoperidine, which is an antibiotic, and 5-amino salicylic acid. That's NSAID. All right, so you have an anti-inflammatory, you have an antibiotic. Kind of ticks off some of these things off the list. I don't think you actually need to know this. You need to know the actual drug name, but you don't need to know what it's a combination of. But just know that's how it works. You also want to reduce things like the autoimmune response. So you want to give immunosuppressants. You can give 6-mercaptopurine. Isn't that the chemo drug? That's a pretty darn strong immunosuppressant. You'd be absolutely right. It's a chemo drug. So this is used for immunosuppressant. If these fail to work, then we do have a cure for ulcerative colitis. What do we say that was? You just resect the bowel. It's a resection. That's ulcerative colitis. Let's talk about Crohn's. Crohn's, our mainstay is really focusing on dampening this autoimmune inflammation. So you can give things like corticosteroids, that's common. Monoclonal antibodies against cytokines like TNF alpha to, again, reduce that inflammation. The main ones you need to know is adalimumab or infliximab. All right. And you can also get them to stop smoking. That's the environmental factor. Stop smoking if you have Crohn's. I just want to touch on this really quickly. All studies show that smoking makes Crohn's worse. But in terms of ulcerative colitis, smoking actually improves the symptoms of ulcerative colitis. Now, does that mean that you're going to tell patients with ulcerative colitis to smoke? No, it's not worth it. There's much more damage done by smoking than benefit. But I've seen a lot of questions that have to deal with this. So just know that smoking seems to benefit ulcerative colitis, but smoking harms Crohn's patients. All right, that is IBD. Hope you enjoyed it. Hope we clarified some things. Thanks.